Thank you very much for having me at this conference. In the next 25 minutes, I will talk about the use of the direct oral anticoagulants, the DOACs, in special patient populations, and we'll make some clinical take-home points along the way. I have no disclosures relevant to this presentation. And I want to talk about the use of apixaban, dabigatran, edoxaban, and rivaroxaban in 6 different patient populations: patients with renal failure, severe obesity, anti-phospholipid antibodies, cancer, and specifically the myeloproliferative neoplasms, unusual site thromboses, and finally, some high-level athletes. First of all, the use of direct oral anticoagulants in renal failure. Now, we all know that the DOACs are partially cleared in the kidney. Apixaban the least, 27% of elimination is through the kidney. Rivaroxaban a little more through the kidney, 33%. Edoxaban 50%. And dabigatran is quite a bit excreted through the kidney. So the question comes up, which of these anticoagulants can we use in renal impairment? And obviously the most attractive one is apixaban. There's been a recent meta-analysis from 2022, a systematic review of the efficacy and safety of anticoagulants in advanced chronic kidney disease. I want to highlight a few points from this meta-analysis. First of all, they looked at recurrent VTE, and I must say I'm mostly focusing on venous thromboembolism in my talk because that's what I do as a hematologist. I do very little of atrial fibrillation management or clinical input into the management of those patients. So in recurrent VTE, patients with a somewhat impaired renal function with a creatinine clearance of 30 to 50 mils per min. And if you look at the overall assessment from the published data, in these patients, the direct oral anticoagulants are favored compared to warfarin in respect to preventing recurrent VTE. And if we look at the risk for bleeding in the same patient population, you also see that the direct oral anticoagulants are favored compared to warfarin and lead to less bleeding. So this is pretty straightforward. Mildly impaired renal function, the DOACs are a good choice and in general better than warfarin. Now, when it comes to patients with hemodialysis, and this same systematic review has listed the renal function right here in orange from good to intermediate to somewhat impaired and more severely impaired, and then hemodialysis patients. And here are the drugs listed, as I showed you earlier, reflected by, or the order is reflected by how much they're cleared in the kidney. Apixaban is the #1 choice for all of these indications. And in patients with hemodialysis or severely impaired renal function, this phase means consider the use with caution. But with mildly impaired renal function or moderately impaired renal function, the apixaban is a good choice. Now you see that with the other anticoagulants in severe renal impairment, including hemodialysis, they should not be used. So apixaban is my and should be our go-to medication in patients with significant impaired renal function, and it can be used in patients with hemodialysis, but we should use it with caution. If you are dealing with atrial fibrillation, I've put in here from the same publication the similar graph. And again, apixaban is a drug of choice. Again, with hemodialysis, severe renal dysfunction, one should think twice whether one wants to use it. If there is moderately impaired renal function, a dose reduction of apixaban is appropriate. The other anticoagulants would not be the choices in renal impairment. So my take-home point here is that in renal impairment or hemodialysis, or in more severely impaired renal function, apixaban is okay or reasonable to use, which includes hemodialysis, preferably not use the other DOACs. And the apixaban, if I use it in hemodialysis, which I do, realizing that in hemodialysis, any anticoagulant leads to a higher risk for bleeding. That's true for warfarin as well as for Eliquis. But I use the standard dose particularly in the heavier, younger, and the patient with lower risk for bleeding person, the traditional treatment. However, I tend to use the lower dose in the patients who had low body weight, who are elderly, who have comorbidities, and who had higher risk for bleeding. The use of DOACs in severe obesity, and severe obesity defined as more than 120 kilos body weight or a body mass index above 40. Now, you're likely well aware of the ISTH guidance document from the International Society for Thrombosis and Hemostasis from 2016, which at that time looked at the use of the DOACs in patients with severe obesity. Now, that guidance document has been replaced by the more recent redo of this guidance based on the more recent data that have come out in the last 5 years. And this is a guidance document from 2021. And what this new guidance document really shows, evidence based on review of the literature, is that up to a body mass index of 40 and up to a weight of 120 kilos, the use of any of the direct oral anticoagulants is reasonable. And that's the same as what we had in 2016. The new thing now is that above a body mass index of 40 or a weight of 120 kilos, rivaroxaban and apixaban are reasonable choices. These are the data that have been created in the last 5 years and have moved the field forward. By 2021, there were fewer data for apixaban, so my preference had been rivaroxaban. In the last 1.5 years, there have been additional sub-analyses and some publications on the use of apixaban in severely obese patients, so that by now, October 2022, I feel comfortable either using rivaroxaban or apixaban in the severely obese patients. The story is a little different in patients after bariatric surgery, and that's any kind of bariatric surgery, either the Roux-en-Y surgery or gastric banding or partial gastric resection. The ISTH guidance document states that in the acute post-operative phase, use a parenteral anticoagulant. And the reason is that all the anticoagulants, warfarin as well as the DOACs, absorbed in the proximal small intestine, rivaroxaban even in the distal stomach, but then all of them in the duodenum and the proximal jejunum. So the absorption is distorted and is changed after bariatric surgery. And we don't know how much is absorbed if we just dose standard by traditional dosing. So the recommendation by the ISTH guidance document is to avoid the DOACs and warfarin in the acute phase and use a parenteral anticoagulant, which is more reliable. And then after maybe 4 weeks, maybe 6, 8 weeks, at some point, once the patient has stabilized after the bariatric surgery, it may be reasonable to switch to warfarin or a DOAC. It can be considered. However, if a DOAC is used, we still don't know how it's absorbed, and then it would be appropriate to do a trough plasma level testing of an anti-10A or a drug-specific drug level. And that's a practice that I do as well. Topic 3, the use of the direct oral anticoagulants in antiphospholipid antibody syndrome. And this is the true full-blown, repeatedly and clearly positive antiphospholipid antibody positive syndrome. You know there has been some concern about the use of the DOACs in patients who are particularly prothrombotic, who are triple positive for lupus anticoagulant, anticardiolipin, and anti-beta-2 glycoprotein 1 antibody. And there have been 3 randomized trials in this population, and I've listed them right here. The first one was a TRAPS trial, a moderate size of 120 patients, and patients were randomized in this trial as well as in the next one, the AUDI-RUST trial, a little bit bigger. They were randomized between rivaroxaban and vitamin K. after they had been treated for at least 3 months with some anticoagulant, which typically was warfarin. And the first trial enrolled patients who were triple positive, so the particularly prothrombotic individuals. And what was seen is that recurrent clots were significantly more common in the DOAC group, so high failure rate. And the failure were typically arterial thromboses, 12% on DOACs, none on the vitamin K antagonist. And at this point, the concern came up that we should not be using the DOACs in triple positive antiphospholipid syndrome patients. The Audi-Ross trial showed very similarly that there was a higher rate of recurrent thrombosis or of anticoagulation failure in the DOAC group. And again, it was mostly arterial events in the DOAC group. In that study, 2/3 of the patients were triple positive. So again, fairly prothrombotic individuals. The third randomized trial looked at apixaban versus warfarin. Very small trial, had to be prematurely stopped, had difficulty enrolling, then funding was withdrawn. The study protocol was changed a couple of times while the study was ongoing. So really, the conclusions are very, very limited. I can tell you, though, that triple positive patients were about a third in this study. There was a somewhat higher rate of failure of the DOAC, of the apixaban, and again, it was arterial events. So that's much in keeping with the other two studies, but very limited data. And then no data on dabigatran. And this was a retrospective study, and I've put it up here just for completeness sake, and you can read it up. But retrospective studies have significant limitations. So the conclusion really in APLA syndrome is a higher thrombosis recurrence on a direct oral anticoagulant in patients who were on a vitamin K antagonist who have been switched to a DOAC, and this is mostly due for the triple positive patients. We do not know whether the single positive patients or the double positive patients also have a higher DOAC failure rate. So while I tend to avoid the DOACs in the triple positive patients, the very prothrombotic ones, I am much more aware that I don't have good data. How do the single and double positive patients behave? Now, the studies or the data have led the ISTH to the following recommendations. We recommend that for the treatment of thrombotic antiphospholipid syndrome among patients with any of the following high-risk situations, VKA, the vitamin K antagonist, should be used instead of DOACs. And that's true for the triple positive patients. And really, that's the only population where we have solid data from the studies I showed you. The ISTH continues that they would prefer to use VKAs over DOACs in patients with arterial thrombosis, in whom we use anticoagulation. And I agree with that, even though we don't have the data for that. But since there is a DOAC failure rate with arterial events, it makes some intuitive sense to not use the DOACs if a patient had an arterial event and has antiphospholipid syndrome and needs long-term anticoagulation. However, the question really comes up, should those patients only be on anticoagulation or anticoagulation plus aspirin, or maybe they should only be on aspirin? That question is not settled. And then the ISTH concludes also that small vessel thrombosis or heart valve disease patients with APS should be on VKA, even though there were no data that are in existence. There are no data that would support this conclusion of the ISTH guidance document. So I do not feel as strongly as the ISTH guidance document does about that. So my take-home points on this is, in general, in patients with full-blown APS, particularly the triple positive ones, I prefer warfarin. However, if the patient has done well on it, has already been on a direct oral anticoagulant for 2 or more years, I don't switch to a VKA. And then we have those patients who hate to be on warfarin or whatever vitamin K antagonist you use. And in those patients, is maybe the bigotranin option, no data, or low molecular heparin, no data, or fondaparinux, no data. But those are non-evidence-based decisions that we can choose after discussion with the patient. What about the use of the direct oral anticoagulants in patients with cancer, including the myeloproliferative neoplasms? Well, I would think most of you, if not all, are familiar with the studies that have been completed, prospective, randomized, large trials, as you see by these numbers, that compared one of the direct oral anticoagulants with a gold standard, or with what used to be the gold standard in cancer therapy, dalteparin. And all these studies have shown that the DOACs are a good treatment option for patients with cancer and VTE. They're at least as good as the low molecular heparin. And in many individuals' practice, the DOACs have replaced low molecular heparin because they're easier to take, at least in my country, often less expensive than low molecular heparin, even though it's still expensive. And there's conglomerate of data show that apixaban is as effective and safe as low molecular heparin. Rivaroxaban and edoxaban are more effective than low molecular heparin in the patient with cancer and VTE, but there's more bleeding. But overall, they are non-inferior to low molecular heparin. So yes, we can use the direct oral anticoagulants in cancer patients with VTE. Question that comes up in clinical practice: once we've treated a patient with full dose anticoagulation for 6 months, can or should we dose reduce the anticoagulation to some intermediate secondary prophylaxis dosing? And we don't have data to tell us what to do. There's been one study, it was non-randomized, that simply looked at apixaban use at the lower dose once the patient had been treated for 6 months with full dose anticoagulation. And they showed that if you then use the lower dose, yes, there is a failure rate of apixaban, and we know there's a failure rate always with any anticoagulant in cancer therapy, but the failure rate was not enormous, and the apixaban 2.5 BID was relatively safe, even though there was some bleeding. But it does not really answer the question whether 5 milligram BID long-term or 2.5 BID would be more appropriate. But there are 2 ongoing trials, and I've listed them right here. One is the EVE trial, and the other one is the ongoing APICAT study. And the results will be coming out in the next year or so. And these studies looked at the use of the lower dose 2.5 BID of apixaban compared to 5 milligram BID after the initial 6 months of anticoagulation with full dose. So stay tuned. And what about myeloproliferative neoplasms and venous thromboembolism? And this is any of the MPNs. If they've had a venous thrombotic event, should we use warfarin, or what are the supportive data to use the direct oral anticoagulants? And relatively recently, in 2021, there was a systematic review of antithrombotic treatment for VTE in patients with MPNs. And the authors identified 10 studies that were relevant for the synthesis. And there was one prospective cohort study, but not any randomized trial. There were 8 retrospective series and 1 case series. So you can already tell that the data are limited, they're biased. We are missing the comparative randomized trial. So any of the data that come out of this study have to be taken with a grain of salt. And there's a lot of individual wiggle room and non-evidence-based decision-making whether one uses a vitamin K antagonist or a direct oral anticoagulant. But before I show you the data, I will show you the 3 conclusions from this systematic review. Number 1, anticoagulation together with cytoreduction may lead to the lowest risk of recurrent thrombosis, with a focus on if a patient has an MPN and had a VTE, anticoagulation by itself is not appropriate. It needs to be combined or should be combined with cytoreductive therapy. Secondly, the VKAs are typically most commonly used in MPN patients, and that's not a surprise because some of these studies are not the most recent ones. But the authors conclude the DOACs may be a reasonable alternative. And they say maybe because it's a limited number of studies. And finally, appropriately, they say there's a high risk of bias of these data because the limitation of quality of data, there's clinical and statistical heterogeneity, and there's low certainty evidence for all strategies. So we cannot be dogmatic and say you need to be on warfarin or vitamin K antagonist, or you can safely be on a DOAC. We just don't know for sure. And this paper may be worthwhile for you to pull if you're involved in MPN treatment, but it looks at the different antithrombotic therapies, antiplatelet therapy, vitamin K antagonists, the DOACs, and then anticoagulation plus antiplatelet therapy or no therapy. And in red are the people who had this therapy plus cytoreductive therapy. In blue, the patients had only this antithrombotic therapy. And you see, number one, the cytoreductive therapy together with this antithrombotic therapy was always better than just the antithrombotic therapy alone. Secondly, you see there's a high failure rate. This is 30% recurrence thrombosis in any of these therapies. Antiplatelet therapy, high failure rate. Vitamin K antagonist therapy, high failure rate. DOAC, high failure rate. And double therapy, even higher failure rate. So even though we give anticoagulation, we need to keep in mind there is a high failure rate. And then the use of DOACs in unusual site thromboses. And I only have one slide on that. This is a really extensive topic and would be interesting and relevant to talk about all these individual unusual clots, cerebral and sinus vein thrombosis, retinal vein thrombosis, the various splanchnic vein thromboses, portal vein, mesenteric vein, splenic vein, etc., renal vein thrombosis, or gonadal vein, ovarian vein, testicular vein thrombosis, or even the skin thrombotic disorders like livedoid vasculopathy. The issue with these unusual clots is, in general, we have few data as to how should these patients best be treated. If they have an unprovoked event, do they really need long-term anticoagulation? Or can 3, 6, or 12 months be sufficient? In retinal vein thrombosis, we often do not give anticoagulation. So the first decision is always, should this patient be on long-term anticoagulation or not? And then the second decision is, what anticoagulant drug do we use? And there's some case series and retrospective data looking at the DOAC use, but none of them are solid enough that we can, again, be dogmatic that the DOACs can be safely used or they are better than vitamin K antagonists or not as good. It's a really individualized decision in every patient. And in general, if an anticoagulant is indicated long-term in patients with these clots, if it is indicated, I have a low, well, how should I phrase it? I am willing or I am comfortable using a direct oral anticoagulant in most cases, unless the patient had high risk for bleeding, where I need to have a reversal agent available. And often the reversal for warfarin, prothrombin complex concentrates, are more widely available than the more specific andexanet reversal agent for the anti-10 agents or the Praxbind for dabigatran. And then finally, DOAC use in high-level athletes. And you may not be exposed to this, but it's an interesting topic, and I take an interest in that. Well, patients or individuals, patients who have some recreational sports, not high-level, bicycling or parachuting or whatever sport you individuals do, if they do it once per week or once per month, it's reasonable to discontinue the anticoagulant shortly before before the activity. And we can use the half-lives to determine when to stop, and that's typically 1 to 2 days before the activity. And then they can engage in the activity without undue bleeding. Now, that's not true in the patient who is an elite athlete who races frequently or plays soccer frequently and practices, and is at high risk for bleeding if he or she is on anticoagulation. And in those people, I have started for the last few years to do individualized pharmacokinetic studies to see how quickly does the drug disappear from the bloodstream. And I do that because all the anticoagulants have a wide inter-individual range in blood levels. And I want to know in the individual I'm seeing, at what time point after intake do they reach a minimal level when they can engage in contact sports. And if I do an individualized PK study, I can identify that. I can tell the athlete, you need to have been off for at least 16 hours before engaging in car racing or football playing or soccer playing. And that way we can get some of the individuals back to their elite sports. And then the question comes up when to restart afterwards. And we've published on that. And if you're engaged in these patients, certainly this is available for you on the internet. So with that, I thank you very much for your attention, and we have time for questions, I think.